So the first topic for today is cellulitis. Cellulitis is a term that is used to describe an inflammation of the skin and subcutaneous tissue. So inflammation of the skin and subcutaneous tissue due to Streptococcus pyogenes and Staphylococcus aureus is called cellulitis. So because it's an inflammation of the skin and subcutaneous tissue, so signs of inflammation such as erythema, pain, swelling, and systemic upset such as fever may also be found. Cellulitis is common on the shins. So if someone presents to you with erythema, pain, and swelling on the shins, then you will suspect cellulitis. There's one more condition that is common on the shins, and that is erythema nodosum. Painful or tender red nodules on shins, then your diagnosis will be erythema nodosum. And erythema, pain, and swelling, then you will suspect cellulitis. Now, depending upon the severity of the symptoms, cellulitis is divided into 4 classes. That is class 1, 2, 3, and 4. What is class 1 cellulitis? There are no signs of systemic toxicity, and the person has no uncontrolled comorbidities. So no signs of systemic toxicity. What are the signs of systemic toxicity? The signs of systemic toxicity, they include acute confusion, tachycardia, tachypnea, hypotension, and comorbidities such as chronic venous insufficiency, peripheral arterial disease, or morbid obesity. These are the conditions which may complicate or delay the resolution of infection. So depending upon these signs and symptoms, cellulitis is divided into 4 classes. Class 1 is there's only redness and pain and swelling on shins. There are no signs of systemic toxicity, or the person has no uncontrolled comorbidities. Class 2 include the person is either systemically unwell or systemically well but with comorbidities. So class 2 is systemically unwellness or comorbidities such as chronic venous insufficiency, morbid obesity, and peripheral arterial disease. So if either one of them is present, then we will call it as class 2. But if both of them are present, then it will be known as class 3 cellulitis. Such as if the person has systemic upset such as confusion, tachycardia, tachypnea, hypotension, or unstable comorbidities. If both of them are present, then it will be known as class 3 cellulitis. And class 4 cellulitis is the person has sepsis syndrome. The person has developed sepsis, which has led to some organ failures, then it will be known as class 4 cellulitis. So which patients do we need to admit for IV antibiotics? Remember that class 3 and class 4 cellulitis is admitted in the ward for IV antibiotics. What are the other indications to admit a patient with cellulitis? If rapidly deteriorating cellulitis, for example, extensive area of skin is involved, then we'll admit the patient as well. Class 3 and class 4 cellulitis, if patient is younger than 1 year of age, if the patient is immunocompromised, and if the patient has significant lymphedema, and if the patient has facial cellulitis or periorbital cellulitis, then we need to admit the patient to manage the patient in the ward. Regarding class 2 cellulitis, Admission may not be necessary if the facilities and expertise are available in the community to give intravenous antibiotics and monitor the person. So if the facilities are not available, then we'll admit a patient with class 2 cellulitis as well. Because a person with class 2 cellulitis either has systemic upset or has a comorbidity that can decrease the clearance of the infection. Now, what are the antibiotics that we need to give? Whenever the causative organism is Staphylococcus aureus, the first choice antibiotic will be penicillin, anti-staphylococcal penicillin, that is fluoxetine. So the diseases that are caused by Staphylococcus aureus, the first choice antibiotic will always be fluoxetine. And if someone is allergic to fluoxetine, then alternative to penicillins, if someone is allergic to penicillin, they include clarithromycin or erythromycin. Remember that erythromycin is safe in pregnancy, so it can be used in pregnancy. Otherwise, we prefer clarithromycin. So fluoxetine is the first choice antibiotic, and if someone is allergic to fluoxetine, then we'll use clarithromycin or erythromycin. Now, first choice antibiotic if the infection is near the eyes or nose. If infection is near the eyes or nose, then we need to give coamoxicillin. And if infection is near the eyes or nose and someone is allergic to penicillin, then again we'll give clarithromycin with metronidazole. And if MRSA species are suspected, then the drug of choice for MRSA methicillin resistant Staphylococcus aureus is vancomycin. But if vancomycin is not given in the option, then the second choice that we have is teicoplanin or clindamycin. So you can see that clindamycin can be used in MRSA species, or clindamycin is a second line drug for MRSA species. The first line is vancomycin, and the second line is teicoplanin or clindamycin. So overall, the first choice antibiotic is fluoxetine. If someone is allergic, then clarithromycin, and if his infection is near the eyes or nose, then we use coamoxicillin, and clarithromycin with metronidazole is an alternative. And if MRSA species are suspected, then vancomycin as first line, or second line drugs such as teicoplanin or clindamycin can also be used. The antibiotics in children and in young people under the age of 18 years are same, except in one condition: if the child age is less than 1 month, then you will refer the patient to for a specialist advice. The remaining antibiotics are same in the children and in the adults. First choice is fluoxetine, alternative is clarithromycin. If infection is near the eyes or nose, then coamoxicillin, and if allergic to penicillin, then clarithromycin is metronidazole, and antibiotic for MRSA species is vancomycin. So in short, in the management of cellulitis in both the children and adults, first line is fluoxetine. If there is allergy, then clarithromycin. If the patient is pregnant, then erythromycin. And if MRSA species are suspected, then vancomycin. Remember one more drug that you need to give if the patient is having a severe cellulitis. Then you can include IV benzyl penicillin, because fluoxetine is an anti-staphylococcal penicillin. So to give a coverage of Streptococcus pyogenes, we need to give IV benzyl penicillin as well. Drug of choice for MRSA species is vancomycin, and second line is teicoplanin or clindamycin as well. So this was all about cellulitis and its management. Now, the second bacterial infection, bacterial skin infection, is erysipelas. Remember that the clinical presentation of cellulitis and erysipelas, the clinical presentation of both of them is almost same. That is redness, swelling, and pain. The only clinical difference between erysipelas and cellulitis is that erysipelas is a sharply demarcated lesion, or erysipelas has sharply demarcated borders, while on the other hand, cellulitis has less well-defined borders. So in cellulitis, the border of the lesions are less well-defined, while erysipelas has well-defined borders or sharply demarcated borders. This is the only difference that you need to remember. That is between erysipelas and cellulitis. Clinical presentation and management of both the condition is same. Even the causative organisms are same, such as Streptococcus pyogenes, and Staphylococcus aureus. Fluoxetine, or if person is penicillin allergic, then erythromycin or erythromycin analgesics can also be given if there's pain. Now, another skin infection that is caused by Staphylococcus aureus and Streptococcus pyogenes. So cellulitis, erysipelas, they both are also caused by Staphylococcus aureus and Streptococcus pyogenes. Another skin infection or skin or soft tissue infection that is caused by these bacteria is impetigo. So it is also a superficial bacterial skin infection that is caused by Staphylococcus aureus and Staphylococcus pyogenes. It can occur as a prime infection or as a complication of an existing skin condition. For example, someone with a history of eczema can develop impetigo, someone with a history of scabies can develop impetigo, and someone with a history of insect bite can develop impetigo. Remember that impetigo is very common in children. It's not common in adults, it is common in children. This is one important point to remember to differentiate impetigo from herpes simplex virus or cold sores. So herpes simplex infection is common in adults, while impetigo is common in children. The infection can develop anywhere on the body, but the lesion mostly occur around the mouth. The spread is through direct contact and indirect contact as well, through toys and clothing and equipment, etc. What are the typical features of impetigo? Golden or honey color crusted skin lesions that are usually found around the mouth. So in Plab 1 exam, whenever you see golden or honey color crusted lesions that are found around the mouth, then your diagnosis will be impetigo. The management is different for localized or limited disease and extensive disease. For localized disease, we'll use topical antibiotics or hydrogen peroxide. And for extensive disease, we'll use oral antibiotics. So if the disease is limited or localized, then hydrogen peroxide 1% cream can be used in patients who are not systemically unwell. And if hydrogen peroxide is not suitable, then we can give a short course of topical antibiotics such as fusidic acid 2% or neprosin 2% if fusidic acid resistance is suspected or confirmed. So hydrogen peroxide, if if the patient is systemically not unwell, and if unsuitable, then topical antibiotics such as fusidic acid and neprosin. if fustigation resistance or is suspected or confirmed. And for extensive disease, again, because the causative organisms are Staphylococcus aureus, so oral fluoxetine, or if the person is allergic to fluoxetine, then we can give clarithromycin or erythromycin as well. Remember that impetigo is a highly contagious disease. That's why children should be excluded from school until the lesions are crusted and healed. So either the children will be excluded from school until the lesions are crusted and healed, or 48 hours after commencing antibiotic treatment. So the child can go to school if the lesions are crusted and healed, or if uh, 48 hours has passed after commencing of the antibiotic treatment. Now, we all know that two conditions are most common around the mouth. One is herpes virus infection, herpes simplex virus infection, which is also known as cold sores. And the second one is that we are discussing now, impetigo, that is a bacterial infection. Both of them are common around the mouth. So that's why you need to remember the features which will help you in differentiating between these two. The first feature that will help you in differentiating between these two is that in impetigo there will be honey color or golden crusted lesions, while in herpes virus the vesicles they contain clear fluid. So if the vesicles they contain clear fluid and there is a prodromal pain occurs before the onset of vesicles, such as tingling, itching, or burning sensation before the appearance of the vesicles, and the patient is an adult and there is a history of recurrent episodes, then your answer should be herpes virus infection, herpes simplex virus infection, or cold sores. So these 4 points are important to remember, because we discussed in the previous lectures that someone with a history of eczema can develop herpes virus infection as well as bacterial infection in the form of impetigo. That's why these 4 points are important to remember so that you can easily differentiate between these two types of lesions that are common around the mouth. One is if there is a history of recurrent episodes, if there is a prodromal pain, if the vesicle contain clear fluid, and if the patient is adult, because impetigo is more common in children. So if these 4 points are present, then your diagnosis will be herpes simplex virus infection. Again, recurrent episode present in adults. Initially, the vesicle contains clear fluid and pain begins before the onset of vesicles. And the pain is usually felt as burning or itching or tingling sensation before the appearance of the vesicles. If these 4 points are given, then your diagnosis will be cold sores or herpes virus infection. Now there's another form of impetigo, that is bullous impetigo. If the blisters that are formed in impetigo, if their size is more than 1 centimeter, or if they are large sized fluid filled blisters, then it is known as bullous impetigo. So again, if the rash is painful and associated with fever, especially in a child with a history of eczema, you will consider eczema herpeticum and give acyclovir or antiviral medication, because child with a history of eczema, they can develop herpes virus infection that is known as eczema herpeticum. So painful and associated with fever, then your diagnosis should be eczema herpeticum. So this was all about some bacterial skin infections. and their management and how to differentiate between different types of bacterial skin infections. I hope it's clear, everyone.